Hello, my name is Dr. Kimberly Cheatham, and welcome to this video presentation on the Pap smear and cervical dysplasia. The objectives for this presentation are listed here. Since the Pap smear was first described by Dr. George Papanicolaou in the 1940s, its use has led to a significant decrease in the occurrence of cervical cancer and related mortality. Those areas of the world that do not have Pap smear screening programs still have high rates of cervical cancer because most women who develop cervical cancer have never been screened or have been screened inadequately. The sexually transmitted human papillomavirus, or HPV, is a necessary although not sufficient factor in the development of squamous cervical cancer. Most women will become infected with HPV in their lifetimes, but do not develop significant cervical abnormalities because their immune systems are able to suppress or eliminate the virus. HPV is divided into two classes, oncogenic and non-oncogenic. Infection with an oncogenic type is required for virtually all cervical cancers to develop. HPV type 16 has the highest carcinogenic potential and accounts for approximately 55 to 60% of all cases of cervical cancer worldwide. HPV type 18 is the next most carcinogenic genotype and is responsible for 10 to 15% of cases of cervical cancer. Some non-oncogenic types, such as 6 and 11, are responsible for the occurrence of genital condyloma. Only a small fraction of women infected with HPV will develop high-grade dysplasia or cervical cancer. The current model of cervical carcinogenesis posits that HPV infection results in either transient or persistent infection. Most HPV infection is transient and poses little risk of progression because it is cleared by the immune system. Only a small fraction of infections are persistent. HPV infection, identified at 1 year and 2 years past initial detection, strongly predicts subsequent risk of high-grade dysplasia or cancer regardless of age. Known cofactors that increase the likelihood of persistence of HPV and subsequent development of cervical dysplasia and cancer include cigarette smoking, a compromised immune system, and HIV infection. Other risk factors for acquisition of HPV and development of cervical dysplasia are listed here. New technologies for cervical cancer screening continue to evolve, as do recommendations for managing the results. The most recent recommendations for cervical cancer screening in low-risk women, published by the American Society for Colposcopy and Cervical Pathology, or ASCCP, are listed on this slide. Note that cytology, or the Pap smear alone, is indicated for screening women between 21 and 29 years of age. After 30 years of age, the recommended screening strategy is a Pap smear combined with testing for the presence of high-risk HPV. A screening test, such as the Pap smear, is most effective when it is performed properly. The technique for Pap smear screening is straightforward, and the clinician benefits by understanding the histology of the cervix. The cervix is the opening to the muscular organ of the uterus. The cervix contains two cell types, columnar and squamous. Columnar cells are tall, thin cells that line the inside of the cervix, an area referred to as the endocervix. Squamous cells are flat cells that are found on the outside, or portio, of the cervix. This area of the cervix is also called the ectocervix. Where these two cell types meet on the cervix is referred to as the squamo-columnar junction, abbreviated SCJ. The squamo-columnar junction is the location of the cervix where most dysplasia occurs, so the Pap smear should include cells from this area. When looking at the cervix with the naked eye, you can often visualize the SCJ. Columnar cells are located in the middle of the cervix and are deep red. Squamous cells are on the outer surface of the cervix and are a light pink. The SCJ occurs where these two cell types interface. This slide depicts the normal process called metaplasia. As a woman ages, her SCJ, which originally started out on the face of the cervix, will move in toward the cervical os. An older patient's SCJ may actually be inside the endocervix and not visualized on exam. This apparent movement of the SCJ toward the cervical os occurs when columnar cells transform into squamous cells at the SCJ during a woman's lifetime. This transformation is called metaplasia. The field of cervical cells located between where a patient's original SCJ was as a young girl and where her SCJ is located now as an adult is called the transformation zone because columnar cells previously located in this area have transformed into squamous cells. When performing a Pap smear, the goal is to obtain cells from the SCJ and the transformation zone because this is where most dysplasia occurs. Every woman's cervix appears different. A woman's cervix can also appear different based on her hormone status. The SCJ is more easily identified in young women when it is still out on the portio of the cervix and during pregnancy as the cervix naturally everts. Can you see the SCJ on the cervix on the left? The cervix on the right is from an adolescent. Her SCJ is located far back on the cervix. Both liquid-based and conventional glass slide methods of cervical cytology collection are acceptable for screening. The conventional Pap smear entails collecting cells from the transformation zone on a wooden or plastic spatula and collecting endocervical cells with a cytobrush and smearing these cells carefully on a glass slide. A preservative is quickly sprayed on the slide, which is sent to the lab for staining and reading by the cytopathologist. Contaminating blood, vaginal discharge, and lubricant may interfere with specimen interpretation. During liquid-based Pap testing, cells are collected from the transformation zone of the cervix and the endocervical canal and transferred to a vial of liquid preservative that is processed in the laboratory. Contamination is less likely to occur with this method. This slide shows the difference between liquid-based Pap smear collection after processing, the slide on top, versus traditional Pap smear collection after processing, the slide on the bottom. You can imagine that the top slide is easier to read for the cytopathologist. However, both methods are considered acceptable. This slide shows the categories of information you will receive on the Pap smear report sent from the laboratory. The 2001 Bethesda classification system is the standard of terminology for reporting the results of cervical cytology in the United States. The ASCCP publishes management algorithms for abnormal Pap smear results. If you are responsible for triaging abnormal Pap smear results in the future, you can refer to these algorithms. The Pap smear is a screening test, not a diagnostic test. The purpose of the Pap smear is to detect cervical abnormalities before they have progressed to cervical cancer, so the patient can be effectively treated. Pap smear results range from normal to LGSIL, or low-grade squamous intraepithelial lesion, HGSIL, or high-grade squamous intraepithelial lesion, and ascus, or atypical squamous cells of undetermined significance. If a patient requires further evaluation of an abnormal Pap smear based on the ASCCP management guidelines, the diagnostic test is colposcopy. Colposcopy is performed in the office by a women's health clinician. The patient is placed in the lithotomy position with her feet in stirrups. The clinician uses a specialized microscope to visualize the patient's cervix under magnification. Biopsies are taken of abnormal appearing areas. Biopsies taken during colposcopy are sent to the pathologist for evaluation. Possible biopsy results may be reported as CIN 1, 2, or 3. CIN stands for cervical intraepithelial neoplasia, or CIS, carcinoma in situ. CIN1 is considered low-grade dysplasia and observation is usually recommended. CIN2, 3, and CIS are high-grade dysplastic lesions that typically require treatment unless the patient is pregnant. Cancer may also be diagnosed on biopsy. If treatment is recommended per the ASCCP guidelines, several options are available, including ablation of the abnormal cells with freezing techniques or with laser, or diagnostic excisional procedures which cut out the abnormal cells so they can be sent to the pathologist for further examination. Excisional procedures include the LEAP, laser, and cold knife cone. This slide shows the equipment used for cryotherapy or freezing of the cervix, a type of ablative treatment for cervical dysplasia. Liquid nitrogen flows through tubing with a metal tip that is applied to the cervix to create an ice ball. A whitish frozen area on the cervix can be seen in the picture on the lower right. Laser can be used to burn away abnormal cells or to cut out cells to send to the pathologist for examination. LEEP stands for Loop Electrosurgical Excision Procedure, LEEP. A wire loop running a current of electricity is connected to a plastic handle for the clinician to use. Abnormal cells of the cervix are cut out and sent to the pathologist to ensure all margins are clear of disease. This is usually performed in the clinician's office. A cold knife conization is performed with a scalpel in the operating room. A cone-shaped piece of abnormal cervical tissue is cut out with a knife and sent for examination. The procedures that remove tissue, laser, LEEP, and cold knife conization, have a small risk of weakening the cervix, which could lead to preterm birth in future pregnancies. This risk should be discussed with patients who desire future childbearing. Are there any strategies we can use to prevent the transmission of HPV? There are 2 vaccines available against HPV. The first vaccine is Gardasil, which protects against strains 6 and 11 that cause 90% of genital warts, and strains 16 and 18 that cause 75% of cervical cancers. It is approved for males and females ages 9 to 26 years. The second vaccine is Cervix, which protects against strains 16 and 18 and is approved for females ages 10 to 25 years. These vaccines are only effective when administered before a patient is exposed to these strains of HPV. That's why it's recommended to vaccinate adolescents before they become sexually active. This concludes this video presentation on the Pap smear and cervical dysplasia.